Hi, it's Callum. We're going to talk about carcinoma in this video. Carcinoma, as you will presumably be aware, is a malignancy of epithelial derivation. So you get any tissue can transform into malignancy. However, far and away the most common type of malignancy is an epithelial based malignancy or carcinoma. So here we've got carcinoma, and I'm going to use colon as an example case, but any epithelial tissue can develop malignancy. But colon cancer is very common, and I think it illustrates the point. This particular case can illustrate the points quite nicely. So up here, we've got an area of the colon which should look a bit familiar to you because we covered it in a previous video, where we've got normal colon, which in which you can see the layers quite nicely. So you've got the mucosa here, submucosa, the muscularis propria, and the connective tissue beyond that. This is the luminal side down here, and this is the patient side with the resection margin up here. It's kind of a bit distorted, so the lumen it's quite difficult. This obviously bulges into the lumen, and that's because the specimen is quite distorted, and that's just what happens, especially in the colon when it develops carcinoma. It can cause distortion of the tissue, and it's kind of the surface is kind of puckered in. That's quite common to see, and that can actually provide one of the challenges when you're taking sections at the trimming bench in order to show the points quite nicely when you come to look at a slide. Because one of the things you want to do when you're looking at colon cancer is to stage it, and that staging is based on the TNM staging. We used to use Dukes, but it's the TNM staging, which is determined by how far through the wall the colon cancer has gone through. So this is a specimen that's T3, although I'm not sure, which means it's gone through the muscularis propria. T2 would be, before that point. However, I'm not sure if we can demonstrate that here, but we'll skip over that right now anyway. So this is normal colon up here. If we follow it round, all of a sudden we get to this vastly different component, and that's the colon cancer. So deciding when things are have become carcinoma forms a big part of your job. A lot of the time, it's easy to tell that what you're dealing with is carcinoma. Sometimes it's much more difficult, especially when you're dealing with small biopsies where you've not got a big section like this, and you've got to make the decision based on a small amount of material. Sometimes it's more difficult because the findings are more subtle. But what we're going to do here is go over the general principles when deciding when something is carcinoma. Some of these features are useful in determining where in other tissues whether they've become malignant, but we'll deal with. But the decision making then can be a bit different. So we'll deal with carcinoma as an example case here. So first of all, at low power, we assess the architecture, and here you can see the architecture is quite different here, vastly different here within this section as it is within the normal. So if we remind ourselves, normally colon is this glandular structure, this test tubes in a rack appearance is very regular, and that's what the normal colon looks like if you remember from the previous video. Here we've lost that completely. So there's no test tubes in a rack, no orderly architecture. You can see that it is trying to form glands. You can see little gland spaces. So it's obviously a glandular tumor. We know that because it's trying to form glands. We might call these abortive glandular formations because it's really attempting to form glands, but they're just not doing a very good job of it. It certainly looks like nothing like this. So this architecture looks completely different. It's lost the normal architecture. However, we can still see some glandular formation, so it is attempting to form something resembling this, and some tumors will completely lose that. There'll just be a mass of cells, and it would be impossible to tell that it was a glandular tumor. And the other tumors will look very similar to this, to the original tissue. And our description of that is the term we use to describe that is differentiation. So if something is poorly differentiated, it has lost its ability to differentiate into the normal tissue structure, and that's poorly differentiated. you couldn't, in a poorly differentiated tumor, you couldn't tell that this was glandular anymore, or of glandular origin. A well-differentiated tumor, conversely, it looks very similar to normal tissue. And moderately differentiated is anything in between, and this is in between. It's trying to form glands, but doesn't look like that. So this is moderately differentiated, and most colon cancer is moderately differentiated. So the other thing about it at low power, as you can see, is this is sort of snaking through the tissue. If you see, it's not nicely bound by basement membrane, as you know, all these glands will be bound by basement membrane, but this is just infiltrating through the tissue. So this has got an infiltrating architecture, and so we know that this is invasive adenocarcinoma. Adenocarcinoma just being the term we use for glandular-based malignancy. So this is all broken through the basement membrane, and I can prove to you that in a different way. So if we look closely here, first of all, the normal, these glands are all nicely separated from each other and we can, you know, that'll have basement membrane at the bottom of all of these glands. Whereas if we look here, if we look at this attempt at a gland and this attempt at a gland, there's no basement membrane here, and we can tell that because basically there's just cells, you know, a mass of cells in between these, joining these glands, and the same between this one and that one, and this one and that one. You know, they've not got a nice outline where you can imagine basement membrane would be. And this is when we see this mass of cells with punched out holes in it, we call that cribriform. It's like a cribriform architecture. When you see a cribriform architecture, there's definitely no basement membrane there in between these glands. So these have infiltrated through the basement membrane and joined up together. So this is definitely invasive. That's another way you can tell with carcinomas whether they've been invasive. And that's useful in other tissues as well. So it's invaded through the basement membrane. We've lost our normal architecture. So that's our low power findings. And then at high power, if we look in closely here, we can see the cytology. That is the description of how the cells look, or the cell morphology. And the cytology within epithelial tumors, deciding whether the cytology is malignant, we use the same criteria in most tissues. And that's nuclear pleomorphism. That is, if we look at the nuclei, they're all different sizes and shapes from each other. There's a kind of roundish one with a central nucleus. If we look, you know, adjacent to that, there's this little one, much smaller. This jagged irregular one is bigger again. That's a big one. There's a smaller one. You know, if we look all over here, they're all over the shop really, all different sizes and shapes. And we call that nuclear pleomorphism. Contrast that with these, which are all nice and regular. There's a bit of difference in size and shape, but they're all approximately the same size and shape around here. But these are all different. So that's nuclear pleomorphism. They're also a bit bigger as well in nuclei, so that's nuclear enlargement too. They're taking up quite a lot of hematoxylin pigment, quite darkly staining, quite blue. Low power, you can see this looks a lot bluer than that. So it's because it's taking a lot of hematoxylin pigment, and that's called nuclear hyperchromasia. So we've got pleomorphism, increased nuclear size, hyperchromasia, and also there's increased nuclear cytoplasmic ratio. Whereas when we look here, you know, these nuclei, this is a nucleus, this is the whole cell. The nucleus is taking under a quarter of the cell area probably. Here, if we look, that's the nucleus, that's the cell, much less than a quarter in there, maybe a fifth or a sixth of the cell area. But if we look back over here and look at, I mean, the difficulty here is deciding where one cell starts and another cell stops. But if we imagine that this is a cell here, probably, and that nucleus is probably taking up half of that cell area. And you know, this is another one, and that nucleus is taking up a majority of that cell, and so on and so forth. So this is increased nuclear to cytoplasmic ratio, and that's another thing we look for. And we've got a loss of the mucin. There's some mucin maybe produced in this cell and maybe in that one, and you know, some of these cells are trying to produce mucin, but unlike in the normal where we've got big mucin vacuoles, we've got loss of the ability to produce mucin in a lot of these cells. So we've kind of got loss of differentiation in these cells too. Another thing we can see quite obviously is this is a mitotic figure. This is maybe another one. It's quite difficult often to determine what's definitely mitosis, and here's a mitotic figure. There's another one. So there's loads of mitosis going on. There's another one. There's another one. Also, there's lots of apoptosis going on, and I can tell that because some of these nuclei have become really small and pycnotic and dark and condensed, and that's an apoptotic or a cell undergoing programmed cell death. That's due to the high unregulated cell turnover. And in fact, this has gone even further. This is karyorrhexis or karyorrhectic debris, and that's when the cell nucleus just breaks up into little bits. So these cells are uncontrollably replicating. So there's all of these things going on. So nuclear pleomorphism, hyperchromasia, increased nuclear to cytoplasmic ratio, loss of differentiation, mitosis, apoptosis, all of these things. And if let's see if we can look around. So this is a good example of, no, hang on. Let's find a better example of another feature which is sometimes useful to see. See if I can find a good example. So another thing that it's useful to look for is when tumors replicate uncontrollably, they often grow to such an extent that they will outgrow their blood supply, and when they do that, they become necrotic. Now, this tumor isn't really becoming necrotic, but hopefully I can demonstrate some necrosis here. Not a good example. This is what necrosis looks like. So within necrosis, you've got amorphous material, not forming any structures. There's no viable nuclei, and it's just looking pink, with little karyorrhectic debris, so little bits of nucleus there. And that's what necrosis look like. This is a specific type of necrosis, which in the colon we call dirty necrosis, which is within the lumen of glands. And that doesn't just happen in tumors, that happens in, for example, inflammatory bowel disease too. But that's what necrosis looks like. You get different types of necrosis which might look different. So you might get coagulative necrosis, which is due to ischemia, and where you just see outlines of cells. You can get liquefactive necrosis, which is often due to infection. Caseous necrosis, which happens in TB, or spotty necrosis, which happens with the liver. These all look subtly different from each other. But it's beyond the remit of this video to talk about that. But necrosis is the final thing that's often useful to see, is the hallmark of, or is often present in malignancy when it outgrows its blood supply. So if we put all these things together, we've got something with an infiltrative architecture. It's forming glands, so we know it's of epithelial and glandular epithelial origin. And it's got all the features of malignancy, so we know this is invasive colon cancer. Okay, so I'm just going to show you one other thing on this video, just to finish us off. So this will hopefully look familiar to you as a biopsy of colon. We've got the kind of normal test tubes in a rack look here that we've transected. But towards the surface here, we can see something else. So this is actually a polyp, and this is a polyp called a tubular adenoma, which is a very common finding. And I'm just going to go through the features here quickly. So that's a normal gland, small basally orientated nuclei, apical cytoplasm. Up here, if you see this gland, where we've lost a lot of the cytoplasm, there's nuclear hyperchromasia and nuclear enlargement, increase to the nuclear cytoplasmic ratio. We've got loss of the mucin. We've got apoptosis. We've got this karyorrhectic debris going on, and we'll probably see mitosis if we look around. So these have got all of the features that I've just described as malignancy, apart from the key one, which is, unlike the last section when we had that cribriform architecture and the glands were invading, this is all bound nicely by basement membrane. It still has a relatively good architecture. You still see the glands, gland, discrete gland, discrete gland. So this is still all within the lamina propria here. So these have got these other features, the cytological features, which we refer to as dysplasia. And this is, we can grade dysplasia. This is low grade dysplasia. If it got worse, we would call it high grade dysplasia. And that's a defining feature of a tubular adenoma, is that it has dysplasia. But it's not developed the ability to invade. So it's not got the architectural features. It's not invaded through the tissue. It's not invaded through the basement membrane. So this is still in situ. So this is a tubular adenoma with low grade dysplasia, we know there's an adenoma carcinoma sequence. So the worry, they often take these out because the worry is this will develop low-grade dysplasia to high-grade dysplasia to invasive adenocarcinoma. And we know that having tubular adenomas is a risk factor for developing carcinoma. So we take them out. These are often taken out as part of the bowel screening program. So this is the in situ form, if you like, where it's still bound by basement membrane. And you get in situ carcinoma in multiple different settings. We discussed it in the breast with DCIS. You get it in the cervix with CIN. You get it in skin, where it's called actinic keratosis. So you get it in lots of different epithelial settings, where it's developed some of the mutations that will lead eventually, possibly, to developing invasive adenocarcinoma, but still in situ, is still bound by basement membrane. Okay, so that's a quick whistle-stop tour, an introduction to carcinoma. There are many different malignancies that you'll encounter. Apart from carcinoma, you'll see carcinoma in many different settings. And it's a big part of the workload, and hopefully this was a helpful introduction. Okay, I've got, I think, one more video to go, so hopefully you'll join me for that, and I'll speak to you soon.